want to check if the image is fine and there is no blurring before we start. So if anyone can confirm that the image is fine before we continue, is it okay? Is the image quality? Yes. Okay, Kareem, thank you, Dua. Okay, so let's now go to the most lovely portion that we can start description. Thank you. Okay. So what do you think about this X-ray image? And how you describe it? Okay. Thank you. The patient have painless swelling, so you don't have any pain. So do you see any abnormality that make you to think about something? Are you happy with this appearance here? Do you see always like this soft tissue here? What is your differential? Okay. So at least we have this longitudinal soft tissue. Yeah. Thank you, Ada. Good trial. That already this fat plane obliterated by soft tissue tumefaction. So do you have any suggestion before I show you the MRI?
Maybe accessory muscle.
Okay, Dr. Fauzi. It could be accessory muscle, and if it is not accessory muscle, what it could be? Okay, so it is accessory muscle, yeah. What is the name of this accessory muscle?
Soleus.
Soleus, accessory soleus muscle, yeah. So it comes in the level of the tibio-talar joint, and you can see this type of muscles like flexor hallucis longus, peroneus brevis, and posterior to this muscle you can see this accessory muscle. And already you have, when you see the normal, you will find, yeah, thank you. You'll find the fat bed here. So when you recognize this, then it is accessory muscle. Yes, perfect. So let's go to the X-ray again. Just a few starter image cases, then we shift to another level, inshallah. Okay. So what do you think about this one? Do you see any abnormality?
Fracture clavicle?
Yeah, maybe the clavicle have abnormality. What is the clavicle here? What is the abnormality you could expect? So
Maybe post-traumatic osteolysis.
So I will try to ask you something. If there is a trauma in the clavicle and they make fixation, do you see any this patient? For example, if you compare both clavicles, do you see any abnormality?
Ictus excavata.
There is asymmetry, right? Do you agree that the clavicle here level is asymmetrical with the clavicle here? Do you agree with this?
Yes.
So, Doc,
Yes.
thank you, Doc. I don't know your name, but I agree with you that there is some displacement and you can say dislocation. So this is what is called sternoclavicular joint dislocation. And if I show you now the CT, it will be much easier to confirm that, yeah, it is something like dislocation. It should be here, but it is here. So this is what is called sternoclavicular dislocation. Okay. It is not the same patient, but yeah, the same case. Okay. Okay. Let's have a look in this case.
Okay.
Okay. So how you describe it? Like your first description will be about the bone density. You agree that the bone density decreased almost, right? And what about the joint? Yes,
Narrowing and subluxated.
perfect. So how you describe this appearance? Like you want to mention like arthritis, and which type of arthritis you'd like to talk about? If you, is it a degenerative one or erosive one or deposition? Which type you'd like to put it your like top differential here? Yeah. So there is like a destruction and erosions, right? So now you can go to, yeah, perfect. You can go to the differential diagnosis. It will be one of the good differential to put, rheumatoid, perfect, as a good differential.
Yes.
What else?
Gout, TB.
Gout, TB, yes. The patient have again in the elbow, you can see. Can be neuropathic as well.
Yes.
Yeah.
Charcot maybe.
Yeah. So this patient already, he was a rheumatoid patient, rheumatoid arthritis, but just you need to describe the soft tissue swelling as well, and the erosive changes plus the displacement and subluxation. So polyarthropathy, yes, perfect, Marwa, Zuhair. Yeah, maybe if you, maybe if he's in pediatric age group, maybe you can mention hemophilia. Yes.
Or juvenile idiopathic erythropathy.
Yes. Yes. Okay. I hope that it is not very difficult cases because I see. But okay, I will shift anyway to another stage now. But let's take this case. It's not easy, but maybe. Do you see anything that is stable? And what about here?
Vascular necrosis.
Okay.
Coxa magna.
Okay, so it can be um, maybe it can be, but do you agree with that this appearance of acetabulum? If I told you that this patient is in pediatric age group, are you happy with this appearance in this age? Yeah, I agree with you, Justiana. If this patient is adult, you will put maybe one of the good differential femoral acetabular impingement. Yes. What do you think if he is in pediatric age group? Yes, Marwa, perfect. So maybe this patient have what is called developmental dysplasia of the hip. And you can imagine the size of the acetabulum. And regarding the, yeah, I know it's not easy one because this patient presented with it late and you can see the complication, but it is this one. It can present in a bit older age group with this appearance, okay? Let's have this case and then we can shift after to another. So this is the level of the wrist, and when he gave you like this picture, yeah, developmental dysplasia of the hip, the last case, yeah. So what about this case?
And he was consistent.
So this patient come to you with tingling in the hand. Yeah. Look in the median nerve and look in the signal of the high signal of median nerve, right? Perfect. So what do you expect in the stare? So it can come to you with compression, flattening, change in morphology of median nerve, edema, or in the post contrast like enhancement of the median nerve. And the most specific that you find abrupt change in the median nerve. So what do you like to mention after all this? It will be carpal tunnel, yeah, carpal tunnel syndrome. Okay, yes, it will be clinically. You will confirm this clinically, but you will suggest that it could be carpal tunnel syndrome. Okay, I think it's a bit hard cases, so let's start with something more easier. I hope it can be easier. Okay, so what do you think about this appearance? How you describe it? So maybe you can start with the cortical thickening. Yeah, you go to the final diagnosis. Muhammad Zuhair, Justiana, Shayma, perfect. So yeah, you will mention the thickening, and he show you already the lucency inside. So the most typical one, it will be the osteoid osteoma. Perfect. So osteoid osteoma can just present with sclerosis like this. If you're lucky, you can see the nidus, and sometimes you can show it like this appearance, and you can have some deformity, double density. I agree with you. So the most typical it will be osteoid which is like composed of central core of osteoid tissue, peripheral zone of sclerosis. So the age is more important to know. You know this. Yeah, so differential diagnosis of intracortical lesion. Perfect. The symptoms, you know the history. You will ask about the history. So what that will be the history? You expect the history. And
severe night pain.
yeah, and he relieved by small dose of what? Small doses of aspirin. Yeah, aspirin. Yes, perfect. And the treatment, the management, the current management is what?
Radio frequency ablation.
Yeah, radio frequency ablation. Yeah, and they like to show you something in the CT maybe like this appearance, which is a much easier one. Yes. So you can see the nidus, which is here sclerotic, and the lucency surrounding, and in the MRI as well. Okay?
Nidus enhanced in MRI.
Yeah. Okay, so let's shift to another case. I think this one is now is easier. This I think all it will be fine for you. So if I ask you the most important sequence in this case, what it will be?
Focal pigmented villonodular
So the most important, it will be the sequence.
gradient.
Gradient, yes. T to stereo gradient, then you can recognize the effect of the hemosiderin. So you can find the blooming artifact if you have the appearance of the hemosiderin, right? So pigmented villonodular synovitis, they like in the exam, which is easy one. Okay, we already have some cases similar to this one. Okay, let's shift to another one. This patient have prior shoulder injury. I think he makes some annotation for you. Marwa, thank you. Differential diagnosis, thank you for this good differential. Okay, Zuhair, thank you. So do you find the appearance of, yeah, the glenoid and the separation of the bone? And so you will expect that it could be like dislocation and there is Bankert injury. And bony Bankert, because already you see the osseous separation here. And sure that if you go to the CT, it will be much easier to recognize it, right? So osseous Bankert, and what you will expect for the
Heel-sack
surface
lesion.
Hill-Sachs, yeah, Hill-Sachs lesion.
Sac.
So Hill-Sachs, deformity of the humeral head with Bankert, osseous Bankert. So it is like antimony case, very easy one. When you see the Bankert lesion, you will expect Hill-Sachs, and when you see Hill-Sachs, you expect Bankert, right? And both of them have reverse, right? So this one, again, in the MRI, it will be the bony Bankert. Doc, Marwa, Zuhair, perfect. Okay? It's easy one. I think it's better to continue in these cases, or you'd like to come back for the difficult one. It's upon to your request, okay? So what do you think about this lesion? This patient is like young age patient.
Finding Larsen Johnson.
So how you describe it? Nirmin, perfect. How you describe it? How you describe the jumper's knee? You describe what? What this tendon is, the name of this tendon? So patellar what?
Rectus femoris.
Patellar tendinosis, perfect. So patellar tendinosis, and it is related to the inferior, yeah, inferior patellar pool, yeah. So you can see sometimes there is maybe some edema or affection of the
Bony irregularity at the lower pole of the patella.
perfect, with associated with edema and high signal of the
Tendinopathy.
tendinopathy. So tendinosis or tendinopathy of the tendon, then you will ask the patient if he do any sports or he use it like, yeah, this patient already he is basketball player, so you will find the typical history. Then you are going to mention that it will be the jumper's knee, and yes, okay, is it easy one? And maybe if I show you this, I think in the X-ray and in the also in the, you can see the affection of the inferior patellar ball, and you can see the sagittal image with the edema signal in the patellar tendon and the high signal. Okay, so this is what's called jumper's knee. Okay, again, another appearance of this affection of the patellar tendon at the insertion of the inferior patellar ball. Okay, and you can see already in the image that this patient has unfused epiphysis, so it is going that he is in the adolescent age. That means that it could be typical history if you ask him of jumper's knee. Okay, this one I think is very easy, and you should recognize it as antimony case, typical for the exam.
Glenbock,
Steinbock, yeah, Steinbock disease, which is
lunate avascular necrosis.
yeah, osteonecrosis of the lunate. It comes between 20 to 40 years old, and it is like, maybe you can consider it as a spontaneous osteonecrosis, unknown cause. So it presents in the X-ray with high density, and it has stages ending by flattening and so Steinbock. And the MRI is much easier for you to detect it. Sometimes, and if it is early in the MRI, you will find just subtle signal. Then you should recommend, you can ask about the history and find the cause if this patient have any predisposing factor to develop the osteonecrosis. Okay? They mentioned that when you find it, most you'll find like negative ulnar variance in about more than 70% of cases. You'll have negative ulnar variance. Okay? Now we have this case in the knee. The image quality today is fine, or to change again is okay, it's fine.
I see a lecture.
Okay. So what happened here in this patient? Can you expect? Yeah. So anterior cruciate ligament tear. The anterior longitudinal, the anterior cruciate ligament. You can see that there is loss of the normal signal of this ligament, which should be like the BCL. So it should be like low signal. Here you can see high signal, and the fibers are disrupted. So ACL tear, which is very easy one. And sometimes there is association with joint effusion, and you can find some edema signal or contusion in the tibia and in the femur. Sometimes they call it like a kissing contusion again along the tibiofemoral condyles. Maybe you can see again the avulsion in the, yes, in the tibial spine. And sometimes they can show you again what is called Seguin's fractures. Yeah, perfect, Doc. Nice, thank you. Okay, until now we take some, yeah, and they have this sign. What is called this sign? in the X-ray, if you are lucky and you see it,
Deep lateral sulcus sign.
deep lateral sulcus sign, yeah, with the ACL complete tear. Perfect. Let's have this one, which is again easy one.
Double PCL sign.
Double D BCL sign, which is referring to
Medial meniscal tear.
medial meniscal bucket handle tear. Yeah, bucket handle tear. Perfect. So the bucket handle tear, when you find the double BCL sign and you find the abnormal configuration of the medial meniscus, then you search for the displaced fragment, which is this one, and it is the bucket handle tear, right? And here again, sometimes this patient in the lateral meniscus, they call it like what?
Flipped meniscus.
Flipped meniscus, yes. So again, the same or same very similar mechanism, that with displacement of the meniscal fragment in the intercondylar notch, and you can find this appearance. Okay. Now time to shift. I hope everyone he will enjoy what is coming next. Just a moment. So we started like last time this type of cases, and I want to confirm that we are much trained in these cases. So let's have something. Okay. So who is the our big star to start with the answer? What do you think about this appearance?
Trimalleolar fracture.
Trimalleolar fracture. So which malleolar you have fracture? In the medial malleolar, lateral malleolus, and
Posterior malleolus.
posterior malleolus. So that's what is called trimalleolar fracture. Perfect. Maybe. It's a bit difficult, but I trust in that one of us will be the big star to detect it. So always check for the alignment and the cortical contour and the cortical continuity. So are you happy with this appearance? Yeah, so perfect. MacBook, I don't know your name, but I think it is tibial plateau fracture. Yes, here. And here also you can see the, yeah, it's not very easy, but okay. Maybe after a while you will recognize it if I show more cases. Okay.
Metaphyseal corner fracture.
Uh, The voice is not very high, but I will try to hear you. What?
Metaphyseal corner fracture.
Okay, tibial fracture. Is it this one
Yeah, so,
or the buckling here?
yeah.
Which one you would like? Is it the buckling here or this one? Maybe I agree with you. Just make zooming, we can see. Maybe the buckling here. What do you think? Because
Yeah,
this one,
both buckling.
maybe both. Okay,
Buckling also and both.
I agree with you. At least you detect the fracture, so thank you. Nermeen, right? Nermeen or Marwa? Which one today? Both? Okay. This one to detect it, the abnormality.
Neck of femur fracture.
Perfect. This is the fracture here, and you can see the fracture. Yes, perfect. So neck of femur fracture.
Stress fracture of third metatarsal.
Yeah, thank you. Marwa, right? Thank you, Marwa. Perfect. Stress fracture of the third metatarsal. I try to focus on the pathology again. Look in this one and compare this one with this one. Do you see any differences between them?
Again, fracture of third metatarsal.
Perfect. So always make in your checklist that you will look in this metatarsals to check for stress fracture, okay?
Second fracture.
Second fracture, lateral tibial plateau. So you expect to see what? ECL tear,
Yeah.
right? Perfect.
Yeah.
ECL tear.
Left sacroiliitis.
Yeah, I agree that there is sacroiliitis here. What else? Shayma, thank you.
Multiple bone eyelids.
Multiple bone lesions. Don't rush for islands because you remember the islands is very small and you are in X-ray. So, and it is not very similar for each other. I mean, there is smaller one and there is a big one and this is another one and this is another one. So you have what is called multiple sclerotic lesions. So what is your differential? You will check for
Normal variant. Maybe met.
Yeah, check first if you have any surgical stippling here or any surgical or if even radiotherapy leads. If you don't have anything for prostate that maybe make you to think about the primary, or if she is like this lady, she is a lady, so you are thinking about something related to breast. So or any primary that give you sclerotic metastasis as first diagnosis. Then you can mention other differential like bone island, but don't rush in bone island because not all patient again this patient you can check.
So what is the most common cause of primary multiple sclerotic lesion?
What?
What's the most cause of this multiple sclerotic lesion, primary cause?
I don't hear well, to be honest, Marwa.
Doctor, what's the most common cause of this primary sclerotic lesion?
For male, it will be the prostate, I think. But lung, you can put a lung in everything. and breast
And
for
female breast. Okay.
yeah, breast for
Okay.
the woman. Yes.
Thank you
So
very much.
yeah. Okay.
Okay, doctor. Thank you.
Again, you have sclerotic lesions everywhere, so you're expecting the same. Another patient with multiple sclerotic lesions. So again and again, and this is a female patient. Again, you have multiple sclerosis. Maybe here you can think about the sclerosis is diffuse, right?
Yes.
So now
بس المحاضرة نص 5 دقايق 10 دقايق.
now I will just show you something. Anyway, okay. This patient come with the bone scan that he mentioned that the bone scan have increased uptake in the left shoulder. I can just read the history. I will tell you exactly. So multiple areas of increased bone scan. I will just show you the real situation. You see with me the report, right? So this is a real situation that the bone scan show. Sorry, can you mute yourself? I don't. Okay, how to mute? Okay, mute all. So this is a bone scan, and already you can see that this patient have multiple areas of abnormal increased tracer uptake along the skull, left lower femur, right knee, right shoulder, and right rib posteriorly. Okay, so now I will show you the scout of the CT. They asked to do like a CT. So do you find anything abnormal here? Are you happy with the
Osteopenia.
Are you happy with this appearance? Or you will suspect something? Hussein, thank you. You add something. Adenocarcinoma from anywhere can be sclerotic. It can give a sclerotic appearance. Okay, thank you. Okay, so I expect that the shoulder, the right humerus, have something. Then when we go to the CT, let's have a look, and you can help me to find any abnormality. So this is a soft tissue window. The image is clear. So what you will do now, if you are in real situation, what you will do? As a basic thing, what you will do? Thank you, Ala. So let's shift it to the bone window. So so what do you see? Yeah. How you describe it? Do you see any osteoarthritis that convincing that could be this one osteoarthritis? No, right? So the joint here is a bit okay. So lytic lesion, nice, perfect. So cortical breaching, lytic lesion, destructive, and it have some areas Yes, you cannot confirm that it has soft tissue or not, but maybe if I change the window now, you can expect here that maybe you are not sure, but at least you have lesion that give you the appearance that is aggressive lesion. Perfect. So what is your first differential? It will be metastasis. Perfect. I will show you more. It can be metastasis, yes, can be if this patient have lymphoma, it can be as well, but you will search for other. Zuhair, take care about the age. So when you mention differential, you should be linked to the age. So this patient did again for, you can see that he again did scout. So before we shift to the CT image, do you find any abnormality that take your eyes, or we should shift to the CT? So we should shift to the CT. Okay. So now please try to concentrate, and because I will show you one time, just one time. So I will see who will catch the abnormality very quickly. If you remember from the history, they mentioned that there is increased uptake along the femora. So did you catch anything abnormal? I show you 2 times now, 3 times. Did you catch it? Yes? No? Okay, come back. Last time, before I will announce the answer. Okay, so time to announce the answers. So take it slowly. Yeah, multiple lytic lesions, perfect. So again, multiple lytic lesions, you will suspect one like this, okay? But this one is very sure that it is lytic lesion, right? Perfect, you saw it. And here again, another one, and here again. So multiple lytic lesion. So what do you expect now to be? Yeah, metastatic. Yeah, perfect. And here also, maybe this one, and here. So you have many lesions. Just maybe you can go to the coronal image and to confirm some of them. Already you can see the one here now is easier one. And yeah, so multiple metastatic lesions, perfect. Multiple metastatic lesion, and this patient, he is known to be a breast cancer. He is known to be breast cancer, sorry. So let's come back for when you find multiple lesion, sclerotic or lytic, search for primary. Sometimes it have diffuse appearance like this, so you can find diffuse sclerosis. Then again, you will think about metastatic lesions. Okay. What do you think about this?
It's fracture of mid of tibia.
Yeah, for the tibial fracture is easy one. Again, what? Second fracture, perfect.
Of Fracture of proximal femur.
Yeah, fracture of, yeah, here in the
Proximal.
end of image, you can see sometimes the fracture in the end, which is very tricky. So take care. Yeah, proximal fracture of the proximal femoral fracture. Can you detect it here? Where is it?
Intertrochanteric fracture on right femur.
Right or left?
Great.
This one or this one?
I think
Okay, let's make some zooming. Maybe it can help us if you are not sure. So this is the
right
right
side.
one? Right, yes.
Right. Yeah, intertrochanteric.
Okay, the right side. Sorry. Okay, now I want to give you a clue, but you already we mentioned this many times. When you have X-ray pelvis of pediatric patient, you have like 3 or 4 diagnoses.
Right Perthes.
Perfect. You see the density of the bone of the epiphysis here compared to the density of the epiphysis here. You can see also some flattening and sclerosis. So you think that it will be right. Perthes, perfect.
Fracture of right neck of femur.
Yeah, neck of femur fracture. You can see the what happened with impaction and neck of femur fracture compared to the left side. So what happened here? Yeah,
Right side
greater.
femur fracture.
Perfect. Greater trochanter fracture. Perfect. So nice. Is it a difficult one? I trust in everyone. So choose your checklist. Try to recognize it. Okay, so the question will be if this is the tibia, right? Are you happy with this appearance? Maybe something normal, but the question will be where is the fibula? So what is the abnormality now?
Absent fibula.
Perfect, yeah. So like there is fibular aplasia, right? You agree with this?
Yes.
Perfect. I think we can skip it because it's not easy one. So okay, just yeah. Again, this one I think is a bit difficult. Not difficult, inshallah, but if you try to make we mentioned that when you have pediatric patient with pelvis, you will think about either births, either other 2 or 3 differential, what it is, what they are. Try to apply the lines. I give you the clue now. So which lines is disrupted here?
Shenton line,
Shenton line, left side or right side?
right side.
Right side. So the right side is disrupted. And what else? If you try to apply this Birkin and H line, maybe it's not, but you can see at least the acetabulum. Are you happy with the acetabulum here?
No.
And the iliac bone? So this is what is called right DDH, developmental dysplasia of the hip, right side. Perfect. Again, we saw 2 cases at least today, so please try to check them.
Stress fracture of metatarsals.
Okay, so if it is this one, stress fracture, so what do you think about this one? If this one and this one and this one stress.
All three stress fracture.
And are you happy with the bone density? I mean, stress fracture is sclerosis.
Charcot joint.
Yes, perfect. Yeah. So think about something else. Think about that maybe neuropathic joint or Charcot joint, because you can see the density, and if you concentrate, you will see maybe some destruction here, right? So yeah, this is Charcot. Yes. Yeah, we already make this. Maybe just I will.
Inferior.
Yeah, you remember,
Inferior
right? Anterior,
rectus
inferior,
femoris.
rectus femoris muscle. Yeah. Just I will shift to another one. Okay. So just we'll take maybe 10 cases more of this type of questions. Then finally, we have the few BIT-CT cases to check them. Okay. I will focus on the pathology, then you are down the hand. So check the joints, the proximal joints, then try to find the abnormality.
Distal phalanx fracture.
Yes,
of
perfect.
thumb.
Yeah, distal phalanx fracture. Now I think it will be easier for you when you are trained in one.
Base of distal phalanx of right thumb fracture.
Perfect. This is the fracture here. Yes, Ala. Thank you.
The distal radius fracture.
Revise.
Base of the first metacarpal fracture.
First metacarpal fracture here. Yes. You can see the alignment disrupted and the fracture is here. It's not easy one, but again, the first metacarpal fracture. Yes. It's not very easy one, but yeah.
Proximal phalanx of middle finger
Yeah, of
fracture.
the index.
Buccal fracture. Yeah, buccal fracture of the.
So this is a fracture here.
Fracture of distal phalanx.
Yes, you can see it now here. Okay. It's not easy, but if you trained in like this, you will find it after that easier.
Fracture of proximal phalanx of index finger.
Yes, perfect. Of the proximal or the metacarpal.
Oh, sorry, metacarpal. Third
Yeah.
metacarpal.
Yeah, so the metacarpal or third metacarpal, yeah. Okay, the head of the third metacarpal. Perfect. It's not easy, but we'll try to help you. So focus in this one. Who our star who will catch it? I will wait a bit until someone catch it. So you see this here. So it is like a fragment bone. So it is like third proximal phalanx fracture. Is it clear? You agree?
Yes.
If you compare it with this one, then you will find the. So now the last piece of our lecture today. Let's go to the PET-CT cases. Okay, and this patient is like 70 years old, and he did this FDJ PET-CT. So he did one initial, and after treatment, he did this one, and again, like a follow-up, he did this one. So, like if you recognize like a lesion in the liver, and if I told you that this patient has cirrhotic liver, so what it will be, your first differential?
HCC.
Yeah, hepatocellular carcinoma, perfect. So hepatocellular carcinoma will be the HC doc, perfect. And after he did the radiofrequency ablation, what happened here? What happened with the metabolic activity? The metabolic activity was
There is no activity.
Yeah, so this means that this is a good response, complete metabolic response. Perfect. And after he did a follow-up again, what happened here in this
There is a increase uptake
recurrence?
nearby.
Perfect, good.
Yeah, recurrence.
Yeah, so this what happened. I think it is easy one. So I hope that you like the BIT-CT images. So yeah, this 6 years female patient, and they mentioned that she have diverticulitis. So what do you see here? What is abnormal here?
Hypodense lesion in the liver, right lobe of liver.
Yeah, this one. And when he did BIT-CT, Hassan, perfect. So yeah, but I will just tell you something. The abscess, you know that the wall of the abscess is like thin. So do you agree that the abscess is not typical to be like this? I mean, the FDG uptake, you can see like soft tissue thickening here in the wall. Rida, okay. So do you think that it could be again like inflammatory, or it could be a tumor? This is the photogenic area. So when you find photogenic area and you find like metabolic activity high surrounding the, so what it could be, the center representing what? What it will be? When you don't, yeah, necrosis, perfect. So when you don't find the uptake in the center of the tumor, this means that necrosis. And when you find necrosis, this means that this tumor is high metabolic activity and it's aggressive tumor, right? That it have much necrosis. So now you can change your mind that it is not abscess, sure, it is necrotic tumor, right? And now you will think, is it a primary tumor or it is a secondary? So do you think that maybe it is it a HSC and this patient cirrhotic liver, or it is metastasis? It will be differential, but they mentioned that this patient was proved to be HSC. Yeah. Okay. And the colon was just diverticulitis. Yeah. And you can see the appearance here. Okay. Let's shift to another image and see. This male patient, he have previous cancer, and it was in the bladder. Yeah, bladder cancer. And do you see any abnormality right now?
Increase uptake in pancreas, head of pancreas.
Nice. So there is abnormal increased uptake in the pancreas, and you can see in the CT that there is some changes here with hypodensity in the pancreatic head. So they suspect that maybe this is a pancreatic cancer, and this is what is called in when you deal with the PET-CT cases, you have entity called second primary. So this patient already have bladder cancer and he is operated from while, but now he developed another cancer, which is the pancreatic cancer. Yes, and yes, okay. Maybe just you can see this. What is this? What do you expect to be?
Metastasis.
Could be metastasis, but from the history, I told you something that maybe you arise that you will think about something related to bladder cancer. If this patient do radical cystectomy, and you know that the FDG tracer goes through the urinary excretion, so what you expect to be this one? Do you know after radical cystectomy what they do, like operation to maintain the urinary excretion? Do you know what they are doing after the cystectomy? So diversion. Perfect, Sarah. Welcome, Sarah. You always come in the right time and give us the good answer. Yeah. So they make like the diversion. So expect that it could be like the pouch for diversion. Sure that if you have the coronal image or the MIB image, it will be easier for you to see it. But yeah, just think out. Yeah, conduit. Perfect. Conduit doc. Perfect. Nice. This patient, 70 years old again, and he have something. What do you see? How you describe it? So let's try to describe it from the CT. What do you find here? 70 years female. So is it a grandma or ma or a daughter? Do you remember?
Serous adenocarcinoma of pancreas.
Yeah, it can be. Yeah, so the typical age, it will be grandma lesion. So it will be, if you just see the
Serous.
CT, serous cystadenoma. Yeah, one of the good differential to put in the top list. Yeah, so nice. And what do you find in the FDG bit CT? What do you find? Is it have high uptake or no uptake or moderate uptake?
In pancreas, no uptake.
No uptake. Perfect, doc. I don't know your name, so mention your name if you like.
Jyotsna.
So, okay,
Jyotsna.
just yeah. Okay, thank you. And no uptake in the pancreas, so lesion in the pancreas, no uptake. So maybe it is like a cystic pancreatic tumor, like serous cystadenoma, which is the case here. So nice. So how would you solve this? What is this uptake here? Is it a metastasis? If you want to mention that this pancreatic lesion is maybe with the calcification, you forget to mention calcification. It's a good sign.
Yeah. Yes.
Sarah again. 10 stars for you, Sarah. Thank you. So it is what is called?
Brown fat.
Brown fat. Perfect, Sarah. Nice answer. So this is the brown fat, so it's not metastasis. Not because of you just find the pancreatic lesion, you will go that everything in the body will be metastasis. No. And again, you can find the normal physiological excretion of the tracer through the bladder. And the heart and the brain, we always talk that it is physiological uptake. So it is not postchondral, it is brown fat, yeah, along the paraspinal and supraclavian region. Okay? Is it a nice case? Is it easy? Clear? Okay. Let's have a look in this. We have 1 minute before we finish. I hope that we can finish this case at the end of session. If you have any suggestion, again, like every time, any feedback, if you want to give any feedback, evaluation, please send me. I will be happy to know your feedback. Okay. So what do you think about here? This patient, 60 years female, again, have a pain and elevated 99, so sorry, 19.9 marker. So you would suspect that there is focal lesion in the liver. I see that, doc, yeah, multiple lesion in the liver with high uptake. So you think that maybe it could be metastasis, and you see the tumor inside the pancreas. So it's typical, like typical case of pancreatic cancer and metastatic for the liver. It is easy one. So when you find elevated the markers, so you're searching for the primary, and maybe in the CT, to be honest, If you don't have the CT, it will be very difficult to detect it, the primary. But with the PET CT, it's very easy to open appetite, and we can see how. I hope that the image is a bit clear. I'll try to make it more obvious. Okay. So I am waiting your reaction. If anyone could H-shaped vertebrae, so nice. Nirmin, Marwa, our stars, big stars. So what do you think about the? I just want to be honest, to show you the central depression, the H-shape. Yeah, sickle cell anemia, the most important, and we mention always like you will search for the other criteria of sickle cell disease. So we can just review what other criteria could be of sickle cell disease. Splenic calcification or auto splenectomy, perfect. What else? Just to put you in the mood. Yes. Acute chest syndrome, avascular necrosis. Perfect. And the most common differential they like in the exam, Gaucher disease, but it have splenomegaly. And they like to put osteopetrosis, but it's a bit different. And the mineralization of bone is normal already. Yes. Okay. So central H-shaped depression. I want just to confirm that the image wise is clear. So what do you think about this? How you describe it?
Sarcoidosis.
You would describe it as sarcoidosis, or you would differential as sarcoidosis? Fauzi. I know your voice. So what do you think? How you describe it? Lace-like, perfect. Lace-like or latex trabecular pattern, perfect. Of multiple phalanges. Lace-like, Sarah, perfect, Sarah. And your top differential will be sarcoidosis. And just good to mention that take care about the articular joint that is preserved. So when you comment about the articular joint, you will not find any erosive changes, right? Then you can differentiate it from other erosive arthritis. Yeah. And you will search for, yeah, huh? You will search for other criteria of sarcoidosis, like what you will like to request if this patient
Chest X-ray.
chest X-ray to find something. If you have already chest X-ray, you request to.
Yes.
Yeah, perfect. Okay. Let's shift to this case, which is easy one. So, what do you like to ask in the history if you find like this case? What is the question that it mean? Nice. Yeah, we will ask about repair, ACL repair. So you will suggest that maybe this patient underwent any intervention before, and this one it will be what is called cycloplegia. So how you describe the cycloplegia? It's like this lobular or nodular lesion, right? In the anterior aspect. And you can see that the signal in the proton density is like intermediate. So it looked like a mass. So what is the most common differential diagnosis you will put? Ahmed Hijazi. Yeah, you will see it in the tunnel, intercondylar notch. Perfect. So what the most important differential in this case? Pigmented villonodular. So you will go and look for the sequence. Which sequence you would like to look for?
Diffuse DWI.
Are you sure?
Yes, because of hemorrhage spot of gradient.
Yeah, so it would be
SWI, SWI.
SWI. So maybe
Yes.
better to mention gradient is easier for you,
Yes.
and to not mix. Okay, so you will search for blooming artifact, and because of the hemocytic. So susceptibility, weighted images, or gradient images. Okay. They like to mention also maybe other something called synovial hemangioma. It could be one of the good differential. I just want to confirm that the image quality today is fine with you. Just to is okay. Because I received request that the image quality is not very nice, so we can change the source. Is okay. I am asking if the image quality is okay. Oh, okay. So when you answer, that means that you are convinced with the image quality, right? Yeah, okay. Marwa, thank you. Thank you for it. So, iliotibial band syndrome, why you mention like this? Because you find fluid and edema signal along the structure which called the iliotibial band. Perfect. Ala, Marwa, Sarah. Perfect. Yes, iliotibial band. And you can see here the T2 fat suppression. You can see what is called iliotibial band friction. They mentioned that sometimes you can see subcortical edema at the tibia, maybe sometimes. And maybe you can see like effusion in the supralateral recess, but important to differentiate between the effusion, the water signal of the effusion just, or it is related to the iliotibial band. So this one, which is related to iliotibial band, it could be like the iliotibial band friction syndrome. And maybe also you ask in the history, like if this patient is runner or he have any history that help you to diagnose this, okay? Then he have the friction, okay? The cause of friction. Okay. So until now, the cases is going with you smooth. So I hope that it will be like this, all of them. So what do you think about this one? So how you describe it? Shayma, nice. How you describe it? Ahmed? Ala. Bulbous epiphysis with deep intercondylar notch, wide intercondylar notch. Perfect. So wide intercondylar notch. So you will ask about history of hemophilia and bleeding diathesis, and sure that the patient most will come to you in the young age, so hemophilia and juvenile rheumatoid arthritis. So enlarged epiphysis and widened intercondylar notch, this is the main clue for you, right? They mention also that maybe there is squaring in the infrapatellar margin. Let's have a look in this appearance. So you can see sometimes in the MRI like a squaring of the infrapatellar margin, inferior patellar margin. Yes. Yeah. They like to differentiate between the juvenile rheumatoid arthritis and the hemophilia. They mentioned that the involvement of the hand and feet and the spine, which one will involve the hand and the feet and the spine? Juvenile rheumatoid arthritis or the hemophilia? Yeah, the spine, involvement of the spine, hands and feet will be the, yes, will be of juvenile rheumatoid arthritis. So this can help you. And also hemoarthrosis after trauma in this age group is common. So maybe sometimes it can be not just hemophilia, okay? It can be also some post-traumatic causes. So take care about this. So we'll ask in the history clinical presentation, and you will search if this patient have any history. Sometimes if you don't have any appearance like this appearance, which is hemosiderin, again you will put differential of pigmented villonodular synovitis. I mean, if you just find this nodular low signal lesions, so probably you will put pigmented villonodular synovitis in your differential as well, okay? Because it have a similar hemosiderin deposition. Maybe what can help you in this case that the involvement will be bilateral in hemophilia. Maybe in the pigmented will be unilateral, usually. Okay? In case that you don't find any differentiating points. Okay, let's go to another case, which is, I think it will be easier. So, what is this antimony case of? Yeah, mud lung deformity. Sarah, Shayma, perfect. Ala, Marwa, Mirmin, yes, mashallah. So mud lung deformity, antimony case. What is the causes of mud lung deformity? So you can find it bilateral. There is underdevelopment of the ulnar margin, as you see. So can be primary or secondary. Yeah, so secondary, as you mentioned, trauma, infection, multiple osteochondroma. Perfect. Bone dysplasia, Turner syndrome. Women are more affected than men. Yes. Let's skip this one, go more quickly. This one for you after the training, I think now it will be very easy for you. Jones fracture, fifth metatarsal fracture, perfect. Transverse fracture through the junction of the diaphysis and metathesis of the fifth metatarsal, what is called Jones fracture, and it is have non-union here because the edges are sclerotic. Okay. We are going to the rapid reporting, so don't worry. We have this today, inshallah. I hope that you can resist with me. Again, what is called this one? Open book fracture, Nirmin. Nice. Perfect. So you can see the fracture here, radiograph of the pelvis, vertically oriented fracture. You can see the defect is easy, but maybe the sacroiliac diastasis. So when you find this fracture, you will search for other fractures, and one of them will be along the sacroiliac. This is what's called open book fracture. It is the second most common type after lateral compression fractures. Okay, let's shift to another one. Nirmin, thank you. Yes, Al-Gigni. This one is very easy one. Yeah, meniscal tear, radial meniscal tear. Perfect. I think it's easy one. Everyone at least see it one time. So this is the tear here. This is just maybe just effusion. Okay. So radial meniscal tear. Perfect. So what do you think about this one? Flattening of the head of second metatarsal. This is what is called Freiberg disease. Nirmin, Ala, perfect, Marwa. So it can be bilateral in 10% of cases, which is osteonecrosis of the head of second metatarsal. Okay. Yes, Freiberg. I want to show you this one. So the history showed that it will help you, but it have characteristic something in the MRI in T2, in the axial and the sagittal. When you have this appearance, you will think about neurofibroma, plexiform neurofibroma, neurofibromatosis type 1, Alaa, Sarah, Nermeen. Yes, all very nice answers. And you will ask about skin discoloration, what is called cafe au lait patches. And you will think about that which nerve it could be. This is along the course of radial nerve. So yeah, neurofibroma, the age is important. The central hypointensity in T2, yes, Sarah, which is the target sign compared to the margin. So this is a characteristic in the MRI. And it can be localized or diffuse or plexiform, the neurofibroma. So this one, it could be the plexiform type. And yeah, the age is important, that affect from 20 to 30, the age group. As we mentioned, the most important, the target sign, and in this case, and the multiplicity of lesions is like pathognomonic. The differential will be the schwannoma. How you can differentiate? Sometimes it's very difficult to differentiate. Yes, perfect. You cannot differentiate easy. That's why you will ask in the history about the skin manifestations and other criteria of neurofibromatosis type 1 that can tell you the answer, okay? I think this one we have in the old sessions of musculoskeletal, we have similar case, but okay, I can show you. This is called, what is called Comel disease. So what is Comel disease? It is like type of osteonecrosis, but in the vertebrae. Osteopetrosis, but in the vertebrae. Perfect. And it have what is called vacuum phenomena, as you see here, right? Yeah. Perfect. This one, I think it will be easy one. So how you describe it? It is like antimony case. I think some of us will know it. Marwa, Nermeen, okay. Marwa, yeah, perfect, Marwa. Shayma. So this is what is called posterior iliac horns. You can see this appearance here and this appearance here. And there is some dysplasia in the iliac wing. If you see the iliac blades on both sides or the iliac bones, you will find that there is dysplasia with appearance of this posterior horns. And there is osteoarthritis of the left hip, and you can see that there is a prosthesis in the right hip. And when you go to see the patella in this patient, how you describe it? Hypoplastic, perfect, Marwa. So yeah, nail patella. So the finding is hypoplastic patellae with posterior iliac horn pathognomonic for something called Fong disease, which is a hereditary, and the other name of this syndrome is nail patella syndrome, right? The age of this patient was like 60 years old, but always like usually manifested, this cases manifested like 20 to 30. Okay, as you see here, this patient is like old age, but usually it presents 20 to 30. The site of attachment, what make this iliac horns, the attachment of which muscle? You can imagine it will be one of the gluteus muscles, which is the gluteus medius. Yes, medius. Yeah, if you saw this iliac horns, they like to show you in the spotting exams or any type of exam, because it's like very famous for this syndrome. Not common, but famous. Okay. Okay, let's talk again about this case in most of our session. So frontal radiograph of the right hip. What is the problem here? So maybe we can approach, is it the problem in the acetabulum or the femur or both? Or maybe we can start with the acetabulum. Okay, so what is the acetabulum here? Are you happy with the coverage of the acetabulum? Is it over coverage or under coverage? There is deficient of the acetabular coverage. Yeah, so under coverage. And you can see that there is already some sclerosis here. So degenerative sclerosis, that means that there is process happening here, right? Perfect. So this patient have pain clicking. They did MRI. Let's have a look in the MRI. You see this high signal in the T2. This is should be the labrum, right? So there is high signal here. Yeah. So when you find like deficient acetabular coverage of the femoral head, and they like to draw in the X-ray like angle from the center of the femur, we call the center to edge. And if it is less than 25 degrees, this is called developmental dysplasia of the hip. You remember our case in the last session, it was again about this. So I repeat it, okay? So, yeah. This angle, and you can see clearly that the under coverage of the we talk about. So the femoral head here is partially covered by the acetabulum. The center edge angle, this angle, used to calculate the coverage of the femoral head. And here they show you that there is under coverage. One line from the center of the femoral head, and the second line to the lateral edge of the acetabulum. The coverage should be more than 25, not less than, or equal at least. Okay. As you see here, this patient is more exposed to risk of tears, as you see the labral tear here. Typically, it comes unilateral. Okay. Is it clear? What do you think about this appearance? What do you like to ask as a next step? Perfect. Sclerotic lesions. So you will ask about sclerotic metastasis as a first differential diagnosis. So if he is a man, what is your expected primary? Prostate, perfect. So now you can confirm that there is in the bone scan multiple areas of increased uptake, pelvic bones, spine, ribs, scapula. If just you look in the pelvis, you can put differential of what? If you don't have any of those lesions, if just you have this pelvis, you will put Paget, perfect, as a differential. But as you have everything in this case random distributed, so it will be the osteoblastic metastasis as a first differential diagnosis. We like to mention that when you make the follow-up, in this case in the bone scan, do you look for the increase in the uptake or the number? When you have like a follow-up in this image, you look for the number, is it increased or decreased, or the uptake? Yeah, most important the number, because something called flare effect, that when you take the therapy, this patient, after he take the therapy, this lesions increase in the uptake. So it gave you like something called false progression. Like this patient, like he have progression, but it's false because this is like increased, paradoxical increase in the skeletal osteoblastic activity, which is not true impression. Okay, so the most important when you look in the bone scan and compare it with this, with the next one, you look for any newly developed lesion. So when you find newly developed lesions, you are talking about progression. If just increase the uptake, and you will ask about the history of this patient, if he taking therapy, then this is what is called flare effect. Called flare effect. Is it clear? Can shift? Okay. Okay, let's finish short cases with this one and go to the next step. So what do you see? Lateral radiograph showing C2 fracture. Yeah. So the fracture here is crossing the lamina, and you can mention that also crossing the pars interarticularis, and associated with what is problematic here in the alignment. It have what?
Enterolisthesis.
Enterolisthesis. Perfect, Nermeen. And you search for any other associated fracture, the most important. Yeah. So this is what is called the hangman fracture. Hangman fracture can be unilateral or bilateral. And always or typically it's associated with enterolisthesis, right? I will mute because I hear my voice 2 times. Direct blow to the face with hyperextension. This is the typical mechanism. Is considered a stable fracture or unstable fracture? Stable or unstable?
Unstable.
Unstable, perfect. It is unstable fracture. Okay, the CT, just I will show you the CT of this patient. Oops. And now the second stage of our session today. So this patient, as you see in the CT, the similar fractures, and it involved the lamina and the bars. Yeah, so multiple fractures, unstable fracture. Okay. Time to shift to the rapid reporting. I hope you will enjoy it. Are you ready, our stars, to the who will catch the abnormality easy? Let's train together in this. Okay. Let's play like a fun. We'll try to make it easy. So I think the image is clear now. Try to activate your checklist to find the abnormality. So who is the first star will be in our night to find this abnormality? So I will try to help you. Just focus in this one. And now focus in this one. Still difficult? Okay, so do you see this fracture? So it is yeah. Okay, ulnar styroid fracture here. Okay. This one similar, but
Trapezium fracture.
yeah, it is ulnar styloid fracture again. You can see here, very subtle fracture. Is it easy now when I make focusing here? Look in this carefully. Can you see it? Or I make zooming? Can you see it now?
Yes.
Okay. So take care with this is one of the commonest when you look in the wrist to check it. Now you will check for everything. What do you think about this one? When you go to the wrist, you have like checklist similar to the foot. When you remember, we check for the less frank and stress fractures and so on. When you go to the wrist, you will go to check for example, the dislocation, for leonate, scaphoid fractures, and what you like to look in the lateral for what is called traquetral fracture. Perfect, Ale. So it's not easy one, but always look in traquetral fracture. Yes. One of the most common sites of fractures, it will be here. It will be the basis of metacarpals. So you look carefully to the metacarpals and look in the bases. So which base here is affected?
First metatarsal.
Yes, Ala and Irmeen, thank you. Yes. First, Marwa, yeah. Now Marwa. When you go to the elbow of child, your first checklist you will search for your first checklist you will search for in the elbow. Yes, supracondylar fracture. So you will search for any supracondylar fracture. Okay. So this one, it is supracondylar fracture. Perfect. And now you like to see this one. So elbow in pediatric patient, you will search for
Fat pet sign.
fat bed sign, which donate the
Pet sign.
supracondylar fracture. So after you check for the lines of the elbow, radiocapitular line, anterior humeral line, check for the fat bed sign if there is any supracondylar fracture. So this one is supracondylar fracture. Again, what happened here?
Supracondylar fracture. Fat
We
pet sign.
elevated posterior fat bed sign. Already you can see the anterior, but the most important to look the elevated posterior fat bed sign as here. And don't forget to check for the radial dislocation. Again and again, supracondylar fracture, elevated posterior fat bed sign. What is abnormality here? He writes for you the abnormality. It is in the index finger, right? So where is the abnormality right now? Okay. Foreign body, perfect. So it can be this foreign body. It's very easy one. Yes. When you find the pediatric patient, as you see here, and you will search for any fracture. And one of the important fractures that you will look for, what is called Salter-Harris fractures. So do you remember Salter-Harris? Can you recognize which type this one?
Type 1.
Yeah, maybe if I make some zooming, you will find that it is already crossing the metaphysis. So,
Type 2.
okay. And if I told you that already crossing the epiphysis as well, it will be?
Type 4.
Type 3 or 4?
Epiphysis means 3 and metaphysis, epiphysis, physis, all crossing, that means 4.
Yeah. So both are 4, and if it's just the upper, it will be the 2, right? Lower, it will be the third one, and both it will be 4, right? So just separation or widening in the physis, it will be 1. Upper in the metaphysis 2, lower in epiphysis 3, both are 4, right? So now can you check which abnormality here? Which one? Did you recognize it? Yeah, it is here. Perfect. I feel that you will answer it. So yeah. So if you consider that the metaphysis is taken here, so it is type
2.
2. Perfect. Now this one is the easy one. When you look for the rest, put like 3 fracture, the most common fracture that come to you in practice. So this one, it will be the most common one in the scaphoid fracture. Okay, and search for any association of scaphoid. Nice. Again, the most common one, it will be scaphoid, especially when you have a scaphoid view. So it is easy one. Again, another example of scaphoid fracture. So who the first star will catch it? Our first star. Okay, we can give him like 10 flowers. If he catch it, it is one of the easy. Anti-mini case, spotting. You are very near, Nermin, to the answer. It is a scaffold you need, but which scaffold you need? Do you remember something like a sign? Yeah, perfect. Dissociation. Yeah, Amna, welcome.
Thomas.
Yeah, Terry Thomas sign. Okay. So now you are satisfied, or you'll search for other fractures? Okay, I will make it easy for you. Look in the 5th, whatever 5th. Try to find any fraction in the 5th.
Yes, the shaft.
Which one?
5th.
5th what? Yeah, the proximal phalanx. There is a fracture. So don't be very satisfied with this. I know that you are very happy that you catch it. I give you the 10 flowers, Amna, Nermeen, Sarah, Marwa. Okay. But don't be satisfied with this. There is another fracture here. Okay. I know that this type of cases are a bit difficult. So don't be upset. Try to train with me, and we are training together until we reach a good level. Okay.
Inshallah.
Okay. The shoulder maybe have some degenerative changes here. The alignment is nice, so there is no dislocation. The problem is here. Yeah. Okay. So the teaching point when you look to the shoulder, always look in the lung, because sometimes this patient have like lung obesity, which can be cancer, carcinoma, or anything else. Okay. This one should be like anti-mini case for you. You should save it. Very important for the exam. You like it? I know that you like the science booby duck. Okay, so this means that it is tracheotomy refraction. Do you agree with me? Whatever the name of the science, the most important to mention that it is tracheotomy refraction. Do you mean it? لا. Nermeen, okay. Okay, and 5 flowers for the sign. Okay. Sorry. Again.
Opiduk.
Okay, so Kobe, look, I don't know what it is, but I know that something maybe similar to duck. Okay. So again, the tracheal fracture, the most important, the lateral, but sometimes you can't see it. You can see the tracheal bone and you can see the fracture. Okay. Again, you see the fragment in the lateral, in the posterior aspect of the wrist. So this is mean that it is tracheal fracture. Okay, is it easy?
Maybe.
Okay, Marwa. So what do you think about this elbow of patient? We mentioned already, you will search for supracondylar. So if it is not supracondylar, what it will be? The second common. Nermeen, revise again. Ala, yeah. 5 flowers of you. So it will be radial head fracture. Radial neck fracture. Yeah, radial neck fracture, radial head neck fracture. Okay. So now it will be easier to detect the lines. So you will try to draw the radiocapitular line. Try now to draw it. Can you draw it easy? Try. If anyone want to draw it, I will accept. So try to draw it. Can you draw it easy, or they have dislocation? And the anterior humeral line as well. So do you agree that it have dislocation? Anterior humeral line and the radiocapitular line. So it should like this and be in the center of the capitulum, right? So it is not. This means that, yeah. Let's make this last one before we go to stage 3 tonight. Yeah, berylinate, Nermeen, perfect. Berylinate dislocation. But you have something, you can add something more. So berylinate dislocation, okay. But what happened with the scaphoid? So berylinate transscaphoid fracture dislocation. Berylinate transscaphoid fracture dislocation. Okay. Now time to take like 2 cases, and I hope it will be nice for you. You can take a deep breath and relax, because we are going to show you something now. I hope everyone is enjoying and they don't suffer with us. So this patient is, I want to tell you that he's 70 years old male, and is good information to know. And this is the X-ray. So how you describe it? Nermeen or Marwa or Ala, and I think there is some absent male doctors. Sarah is with us. Hassan, Khalid, Zuhair, if I remember, Ahmed Hijazi with us. Any want to describe? You will be welcomed. Okay, so how you describe it? Lesion involving the right iliac. Okay, sclerosis. So can you mention like it is diffuse or focal?
Focal diffuse.
Focal diffuse, okay. Focal or diffuse or both? I mean that the sclerosing are more localized here, but already if you compare this with this, I think again you have a sclerosis here, right? And just one thing, Amna add, very nice, thank you Amna. You always come on time, enlargement and thickening. Yes. So there is enlargement and thickening. Okay, I see that someone is sleeping. Okay, we are about to finish. Sorry. Okay. I want to just show you the nuclear. I don't know why it's small. Okay, can just, okay. Okay, but you can see, I don't know why is smaller in size. Okay, anyway, you can see that the uptake is like this, focusing in this. So I see the Nermeen that she suggests, yeah, Paget disease as well. So this case was Paget disease. Perfect. Let's have one more case before we take the okay. So this patient is 60 years old. Very small image. Is it okay with you, the image quality? So this is the proton density with fat set, and this is the sagittal proton density. Axial with fat set. Nermeen, perfect. This is what is called lipoma arborescens. Yeah, lipoma arborescens. And the T1 is the most important. So there is like large knee joint effusion, synovial proliferation within the suprapatellar bursa. Let's shift to the images if they have more. In the X-ray, it looks like this. You can see that there is suprapatellar soft tissue tumefaction. And finally, the diagnosis, what is called lipoma arborescens. Okay. Okay. Yes. Now I think we have the. I see that most of you are sleeping, so let's go to the last stage today, which is some PET-CT cases. We have about 8 minutes. So try to collect the finding. This patient, 60 years old, he already did like operation, and they make PET-CT to make follow-up staging, restaging for this patient. So there is focus here of calcification, or maybe related to the previous operation. But what do you see in the lung here? If you consider this multiple uptakes, foci of uptakes, high uptake, it could be like lung. So it can be like a metastasis, right? And in the osseous bone, you can see in the left sacrum here, there is another lesion. If I told you that this patient, he already have rectal cancer and he did like resection for this rectal cancer, but now he developed this foci in the lung, and this is in the left sacrum. So what would be your differentiation? What will be your diagnosis? So it will be like the metastasis will be your first differential, right? Okay, it is direct. You have primary rectal cancer, so it will be okay. What do you think about this case? This patient, he did initial staging, and you can see that there is something in the rectosigmoid, and when you go to see the uptake, is it high uptake or low uptake here? You can see it. And in the lung, you can see this high uptake focus nodule. And in the liver, there is lesion beside the IVC here. And in the brain, it's not easy to detect the cortical lesion or subcortical lesion because of the cortex, the gyri of the brain usually take high uptake, right? But you can see that there is something here, right? So what do you think about? Okay. There is no answer, so this means that sleeping. So yeah, it will be rectosigmoid cancer, Ala, thank you, and pulmonary liver metastasis. So what do you think about this focus here? Yeah, it is injection site. So this is injection site, and you have like liver metastasis, pulmonary metastasis, and yeah, brain metastasis. Perfect. Again here, let's have a look how it could be. This patient, he did 2 PET-CT, A and B. So what is the difference between A and B? They mentioned that A was for to assess if this patient have recurrence or not. So this patient already have rectal cancer. So from A images, do you see that it could be recurrence or not? If you look in the A images, do you think that there is recurrence or not? Yes or no? Yes, perfect. Because of the high FDG uptake, soft tissue nodules here and here is beside the presumed operation site. So this means that this patient have recurrence. And if you look in B, and now you see this, which is not present here. So this means that it could be progression or regression. When you see newly developed lesion, which is not present here. After few months, he did this one. So this means progression or regression. Perfect, Nermeen. Nice, thank you. So this is what's called progression, okay? I feel that you are tired today, so I will be enough with this last case. I hope everyone was enjoying anyway. So this patient have A and B again with rectal cancer. And one, which is A, you can see this focus in the presacral region. And you know that the operation site will be very near to this. And this one was diagnosed as recurrence. Okay? So he take like a chemotherapy. What he did here, is it regression or progression? I will answer because we don't have much time. So you can see that there is increase. So this means that it is progression. Yes. And finally, look in this side, which is pitfall of PET-CT, that the colostomy site or stoma, it can have some FDG uptake. Nice, Nermeen, thank you for the